Hi, my name is Dr. David, neurosurgeon specialized in pain management. Today's topic is adhesive capsulitis, so-called frozen shoulder. Adhesive capsulitis is a condition that affects only the shoulder joint. Pain gradually progresses and may eventually become severe enough to disrupt sleep. Movement becomes gradually restricted, causing significant impairments in daily life. The diagnosis is made based on the patient's medical history and physical examination, and it is mostly treated with non-surgical methods. Ultrasound-guided corticosteroid injection into the joint are an important treatment, and surgery may be considered if there is no improvement after 6 months of non-surgical treatment or more. In 1934, orthopedic surgeon Earnest Codman discovered a disease that was difficult to diagnose and treat, characterized by loss of movement in the shoulder. He named it frozen shoulder, and in 1945, Julius redefined it as adhesive capsulitis. The cause is thought to be inflammation and fibrosis in capsule and synovium surrounding the shoulder tissue. Shoulder pain between the age of 40 to 70 should always be suspected as adhesive capsulitis. It rarely occurs in individuals under the age of 35 or over the age of 70. The condition typically progresses through 3 phases: a painful phase, a stiffness phase, and a thawing phase. But in 15% of cases, the limitation of joint movement may persist. The incidence of frozen shoulder is reported to be between 1 to 5% of the general population and is more common in people with diabetes. About 20% of diabetes patients were diagnosed with adhesive capsulitis. Thyroid disease, hypertension, heart disease, lung disease, and Parkinson's disease are also the risk factor for adhesive capsulitis. This disease is caused by contracture of glenohumeral capsule, which is the connective tissue that surrounds the joint. The rotator cuff interval, which is shown with triangular shape here, and the corticqosteroid ligament, a structure within the interval, may become thickened and fibrotic. This leads to a decrease in the normal volume of the shoulder joint, which can be as low as 5 to 10 milliliter. The most important physical examination for frozen shoulder is the passive movement test of the shoulder. The range of motion is usually restricted in passive external rotation, followed by abduction and internal rotation. Pain at the end range of motion during passive external rotation is also a characteristic symptom of early frozen shoulder. It is important to differentiate frozen shoulder from other conditions such as rotator cuff tear and degenerative arthritis in shoulder, as they also present with pain and limited range of motion in the shoulder joint. In patients diagnosed with rotator cuff disease, it is important to consider the possibility of concurrent adhesive capsulitis if there is pain or limitation in joint range of motion during a passive external rotation test. Similar to adhesive capsulitis, limitation in passive movement tests may also be present in patients with shoulder arthritis, but crepitus during the movement test and an older age of patient are more commonly associated with shoulder arthritis. X-ray imaging is an essential examination for differentiating bone diseases and can also diagnose osteopenia, which is a complication of chronic adhesive capsulitis. MRI scan can also be used to confirm thickening of joint capsule and surrounding tissues and to show contraction of shoulder and joint cavity. These imaging methods are used to identify specific conditions and planning appropriate treatment. Ultrasound of the shoulder can provide a lot of information when adhesive capsulitis is suspected. On ultrasonography, there's increase in fluid around the biceps tendon and around high aqueduct in the vicinity of the spinatus tendon. The synovial fluid near the biceps tendon is connected to the joint, and joint fluid moves near biceps tendon as the joint becomes contracted. Therefore, the more contracted the joint capsule is, the more fluid increase can be seen around the biceps. Treatment of adhesive capsulitis is non-surgical. Most cases of adhesive capsulitis have symptoms that persist for 3 years, and if left untreated, symptoms can persist for an average of 4 years and 4 months in 40% of patients. Therefore, it is a disease that requires active treatment. Non-surgical treatment options include medication, intra-articular steroid injection, joint capsule hydrodilation, and physical therapy. Intra-articular and intravascular steroid injection can be used as injection treatment. Extracorporeal shockwave therapy has been suggested to have anti-inflammatory. Extracorporeal shockwave therapy has been suggested to have anti-inflammatory and anti-fibrosis effects in the treatment of adhesive capsulitis. The method involves administering 45 to 500 sessions in the rotator cuff interval at the back of the shoulder joint at the outer side of scapular spine respectively. It is recommended to perform the therapy every 2 weeks and to monitor the patient pain level after 3 to 4 treatments. This is all I prepared today, and if you need any medical help, please write a comment below and I will do my best to help you. Thank you very much.